Hi, everyone, and welcome back to the hashtag C Arthritis interview booth. It is my absolute honor and pleasure to be in the studio today with Dr. Hani El-Gabalawy. Dr. El-Gabalawy and I have known each other for many years. We have talked as patient researcher colleagues. We have talked as patient to clinician. We have talked as friends, and it's just an honor to be with you today, Dr. El-Gabalawy, and we thank you so much for your time.
Thank you.
Yeah, I'm going to tell the audience a little bit about you and where you're situated presently, Dr. El-Gabalawy. For our audience, Dr. El-Gabalawy is a clinical rheumatologist and researcher, is a professor of medicine and immunology at the University of Manitoba, where he also holds the endowed chair in rheumatology, research chair in rheumatology. Dr. El-Gabalawy is not one to toot his own horn, but I will. If we took the time to read his curriculum vitae, we would be here all day, literally, in terms of everything that he studied and reported out on, which is a really important part of research. He's actually turned out facing to the public and talked about his research findings, which is critical. But he's widely recognized for his contributions in the field of rheumatology and immunology, with a specific focus on rheumatoid arthritis and Indigenous health. And I could go on and on about Dr. El-Gabalawy, but we're just going to dive in and start our chat. So welcome again, Dr. El-Gabalawy. So I guess first for our audience, we always like to start at the beginning, which is please tell our audience a little bit more about yourself, that area of focus that I just mentioned in clinical and rheumatology research, and anything else you'd like to share with the audience.
Great. Thanks for this opportunity,
Yeah.
Cheryl. It's a pleasure and an honor to be doing this. So I started out in the early 80s as an internal medicine resident at McGill University, looking for an area of focus, as people at that stage do. And as always, it's mentorship, it's running into people who inspire you. And several people at McGill at that time inspired me to do rheumatology, not the least of which is Dr. John Esdale, who was then this up-and-coming star, or junior faculty, just done some great work at Yale and came back, and he kind of inspired me of the rheumatology and the potential career that one could have in it. So I'm very grateful to him for that. I went into private practice for 5 years in Fredericton, and my wife was from there, and we had started our family there, 3 kids, and surrounded by family and friends. And then I moved to Winnipeg in 1990 to pursue a more academic career. I wanted to do more engaged in benchtop research, and it was really a basic scientist by the name of John Wilkins who was the big draw for me. He's an inspired basic scientist who really complemented my interests. And so he had a clinician scientist and a basic scientist working together, and we really accomplished a lot together over the years, not without frequent healthy disagreements, may I add, as clinicians and basic scientists often do. But that's the strength of those kind of relationships. He's retired now after establishing a wonderful Center for Proteomics and Systems Biology here at the University of Manitoba, and I remain one of the principal investigators here, and have incorporated new blood, so to speak, people like Dr. Liam O'Neill, who's a rising star in the rheumatology world as a clinician scientist. So it's good to know that others will be able to follow you in a path that you think is the right path, and that things just don't vanish when you vanish off the face of this earth, so to speak. So
Yeah, it's not
that's my
something
journey.
that the lay public thinks about, is this succession planning in research, and it's so critical, like it is in other aspects of our life. Otherwise, there is you know, kind of like a cliff. So we definitely don't want to see that happen to your incredible body of work. You led a workshop, but you also gave a lecture that is really the keynote, one of the keynote talks at the meeting every year, the Dunlop Doddridge Lecture. So first, congratulations on that incredible honor. So let's first start though with the workshop.
Yeah.
Tell us, give us sort of the Coles notes, if you will, from the workshop in terms of the approaches to rheumatoid arthritis prediction and prevention. So something that's going to be really of interest to our audience.
Yep.
As you know, arthritis consumer experts, a large number of our members across the country live with a type of autoimmune arthritis, if not rheumatoid arthritis, then one of its kissing cousins, so to speak. So you're going to tell us, I think, a little bit about what can be done in terms of prediction and prevention at the individual level, at the community level, and at the national level. So give our audience a little peek into what you talked about at your workshop.
Yeah, I think that many of your folks in your audience would be aware that we now have, through probably a couple of decades worth of knowledge, recognize that rheumatoid arthritis starts long before the joints get sore, the joints get inflamed, the immune system starts to deviate from normal up to 7, 10, maybe even longer, 15 years before things start. And we've learned ways of detecting that. The most readily available being testing for the rheumatoid arthritis autoantibodies in the blood, and finding individuals who would be at increased risk based on having those antibodies in the blood. And just fast forwarding a little bit here, we also know that the people that have the autoantibodies in their blood, a substantial proportion of them never go on to develop rheumatoid arthritis. In fact, the autoantibodies come and go. But we also know that somebody who has autoantibodies is clearly at higher risk of developing the disease down the road. So in this day and age, these are readily detected in every laboratory, in a clinical laboratory. You send a sample in, they test it. And so one of the ideas that we're pursuing is that can we screen large populations for the presence of these autoantibodies, and then based on that, follow these individuals more carefully and try to understand a little bit more about how the disease starts. And that's what we did for the last 15, 20 years through generous funding from the Canadian Institutes of Health Research and other funding agencies. But now we have gotten ourselves into a situation where we're starting to ask the question, well, gee, if we can detect this, what are we going to do by telling people other than just worrying them, right? And so we're really moving into an era where we're thinking, okay, is there an opportunity to do something at a stage before the disease actually manifests itself as joint inflammation that would achieve something that would be not achievable later on, which is to prevent the disease from starting? So that's the premise we're working on. And there's been some considerable activity internationally, mostly on individuals who are very close to their disease starting, and that they have the autoantibodies, but they also have symptoms, stiffness in the morning, pain in the joints. The joints aren't necessarily swollen, so you can't say they have rheumatoid arthritis. They don't meet our current criteria, but we know they're very close. And several prevention studies have been done in this, but particularly in Europe. And so far, what's really been shown is that these have delayed the onset rather than prevented. So we are wondering whether if you go further back and you detect these antibodies before people have any symptoms, knowing that it's not a perfect tool, can we actually achieve more by treating with something further back? So we approach this in two ways. One is the screening of the populations. Two is, okay, once we've screened, what are we going to give people? So in terms of screening, we have developed a finger stick method where you using very familiar technology that you test for glucose levels and things like that. You got a drop of blood on a piece of blotting paper, and then it comes to our lab. we extract the protein from it and test it for the presence of the antibodies. Easy to do, can be done in the home, put in an envelope, sent. So this is the kind of thing we think is scalable to use in First Nations remote First Nations communities, in multiple communities, both urban and rural, and so on. So one of the things we did in the workshop was talked about the strengths and weaknesses of this dry blood spot technology applied to this particular application. And we were really privileged to have world experts like Marv Fritzler and Leahy Eder and Joan Wither and people like that, who are really, leaders and Canadian leaders, and who are, commented on our approach. What are the pitfalls of using this type of approach? So that workshop was very valuable from that point of view. The second, which is, okay, so we've identified people who are positive using this approach or traditional approaches.
And pre-symptomatic.
Pre-symptomatic.
Yeah,
exactly.
okay.
What are we going to do with that? So
Yeah.
we undertook some animal experiments, mouse experiments, a number of years ago. We were inspired by some epidemiologic studies suggesting that the nutritional supplements of vitamin D and omega-3 in quite a large US epidemiological study to prevent cancer and heart disease. It didn't do very well in that, but in the secondary analysis, there was a suggestion that maybe the incidence of rheumatoid arthritis was lowered by this, especially taking the two together. So we also looked at literature that curcumin, which is the active ingredient in turmeric, also had some very potent biological effects in terms anti-inflammatory effects. So we took all three of them, gave them to mice in a mouse model of inflammatory arthritis before it started, and we used them individually and in combination, showed that we could largely prevent the arthritis from starting in the mice using these supplements. So we thought, okay, this might be, these have acceptable toxicity, these are available on shelves and so on. So maybe if we use them early enough, they would do something that would deviate the immune response back to normal and prevent the onset. So that's what we're pursuing right now. So that's the second thing we discussed in the workshop, is the use of this, a clinical trial of this nature, take these supplements. We've already done this in 50 healthcare workers, given them the supplements, shown that it's safe. They don't have, it had all the expected. Yeah. And so if we did that in people who have the autoantibodies, can we do something? The problem is our studies with families of rheumatoid arthritis patients showed that we have to wait an average of 5 years before the disease started from them coming into the study. You can't power a study with that, so we have to come up with surrogate markers in the blood to tell us we're doing something, and that was the focus of the discussion in the workshop. Yeah. Well, what can we use to tell us we're doing something as opposed to just waiting for arthritis to happen? And the third thing we discussed in the workshop was the ethics of treating people with things like, that model's well established with lipid lowering agents like statins, with hypertension, but it's not well established in the autoimmune.
No, and what we're using is significantly different as well. Yeah. Yep. And the potential for toxicity or adverse event, maybe while not great, you still have to balance, the unknown, really.
Yeah, and really, I think the challenge is knowing that you're going to be over treating a lot of people, because as I mentioned, those antibodies come and go, they go away. So you have to do something that's reasonably safe, because you can afford to over treat a whole bunch of people to get that small fraction of people who would otherwise have developed rheumatoid arthritis. You may be able to change that trajectory.
Would that same proposition, though, be true in other chronic diseases, Dr. El-Gabalawy? Like, would other disease communities, in other words, need to make that same pro-con choice when talking about prevention?
Very much so. Very much. It's the same conundrum with chronic disease of various. And I think the advantage here, as I mentioned at the start, is that we do have these antibodies in the blood that becomes a very important indicator of risk for us. Just for instance, as high cholesterol levels are for cardiovascular disease and so on. So, high cholesterol levels don't do anything to you. You don't feel them or anything, but they become a very good biomarker to tell you that individual is at increased risk of developing a heart attack or a stroke. So it's similar arguments with other chronic diseases.
Yeah, unbelievably fascinating. I think this approach using nutraceuticals is obviously really popular already in people like me. I have rheumatoid arthritis. I use a variety of supplements already. So when you think about prevention and you think about possibly using things that are over the counter, you're just basically looking at interaction with other things you may currently be taking, or are those things pure enough? You would need to know that the source is good,
Yeah,
right?
yeah,
So you'd
yeah,
have some of those consumer type questions,
yeah.
but otherwise you're saying the downside is the length of time it takes.
Yeah, yeah, no,
Yeah,
that's right. I mean, we've shown, as I mentioned, the animal model, that there's something specific about that combination. And each of them, there's lots of literature out there about the benefits of vitamin D,
yeah,
and we did some studies showing that in the winter, in our population, the First Nations population, and the rest of the Canadian population, vitamin D levels are quite low
yeah,
because we just don't get the sunshine and so on. So this is particularly important in the winter. The omega-3 story has been around a long time, fish oil, anti-inflammatory, and the curcumin story has been around in other cultures for centuries. And used in cooking and so on. One of the challenges of curcumin and turmeric is that it's absorbed poorly. So we've worked with formulations that improve the absorption of it so that it actually gets some of it. But these are technical things, but we believe that that combination has good potential for doing what we think it might do.
yeah. It's incredibly fascinating. I know that our audience is gonna email us with a lot of other questions, which we'll do our best to answer, but some that we may not be able to, will possibly try to tickle you into providing us answers. I want to sort of focus on a population that you've referred to often in the workshop, and that's First Nations. And I know you've done a lot of work on rheumatoid arthritis and the impact of it on First Nations people, particularly in Manitoba. And I want to ask you, as we are walking the path forward towards truth and reconciliation, and we look to build trusting, culturally appropriate, supportive relationships with our First Nations brothers and sisters. I want to ask you, how do you see us being able to work with communities who are First Nations to detect and prevent diseases like rheumatoid arthritis? How do we bring together um, two distinctly different types of societies? I mean, our First Nations people are indigenous to this land. Colonial settler viewpoints on medicine are different, to be sure, than our indigenous communities. How do we work through the puzzle,
Yeah.
Dr. El-Gabalawy? I know you've spent years doing this work, and I know your interest, as well as our organizational interest, is in working in meaningful, trusting, culturally appropriate relationships. Tell us about your work and what you've learned and what you hope to see moving forward.
Yeah, thanks for the opportunity to
Yeah,
comment on this. It's obviously a very important point for me and for the general context that you mentioned there.
yeah,
So the first of all is you have to make sure that what you're studying, the questions you're studying are relevant and impactful for not just you and your scientific community, but for the people who are going to be studied.
yeah,
So it has to be a common agenda that is recognized as compelling questions. And rheumatoid arthritis, through our work and the work of others, is particularly devastating in First Nations people.
yeah,
Not all First Nations people, but certainly First Nations populations in the plains of Canada and the United States. In the circumpolar areas, for instance, the Inuit and the Haida, and they have rheumatoid arthritis rates that are comparable to any other population in the world. In the plains, in the population, we study the Cree, the Ojibwe, the Oji-Cree, in the US, in the Pima, in the Chippewa, in the Yakima, in multiple populations, the rates of rheumatoid arthritis are 3 to 5 times higher than
Yeah.
any other population in the world. So that's number one. Number two, it's bad disease. And we've shown, why is it bad disease? It's disabling disease. More often than not, it involves disabling joints like the knees, the hips, the shoulders, the elbows. So the levels of disability go, the outcomes are terrible. And we just published a paper with Carol Hitchen last year showing that on average, a person with new rheumatoid arthritis who's First Nations dies 20 years younger than a person with rheumatoid arthritis who's non-First Nations.
Right.
So yeah, no, that's obviously a very complex picture of access to care and biology and sociology and so on.
Concomitant diseases, yeah.
Concomitant disease, but that's
Yeah.
the reality. So it's a compelling problem, and I think so. That's number one, is that the communities have to be aware that this is a problem that needs to be addressed. And I think we've done a pretty good job at that. And we've done that through when we go to communities, you got to show up to the community and be there and be visible, but most importantly, be heard. And we've worked with the local radio stations as a very, very effective way of getting our message across. We have radio call-in shows where people say, hey, what about the weather? All the questions that you expect. But people get engaged with that, and the level of knowledge of the community goes up. So that's number.
And so does trust, which is a really important part. Yeah.
Exactly.
Yeah.
So other things, working with the local health leaders there, the health directors, working with local research assistants who can help, who are connected to both the study and to the community to help with the conduct of the study. And most importantly is having community consent. We're used to thinking about consent to do clinical research, but here's a consent form, you make sure that people understand and so on. When you're working with First Nations people, you not only need individual consent, but you need community consent.
Yeah.
And that's in the form of research agreements, which are worked out on a principle called OCAP, which ownership, control, access, possession, which kind of comments on things like what you can do with samples, what you can do with secondary use of data, secondary use of samples, and so on. All of these have to be incorporated into research agreements. And most importantly, it's not a one agreement fits all.
Yeah.
We have worked with several communities and undertook the study in several communities, and each community is unique and has individual needs and cultural environments, and each agreement has to be unique to that community. So we have an agreement with each community, and each of them has a bit of a different flavor, but all of them have some commonalities around the principles of OCAP and what you can and can't do. So those are the general principles, and you got to show up, and you got to keep showing up.
And as you do in life, it strikes me as I listen to you, Dr. El-Gabalawy, that language is so important, and language is the way through spoken word that we interact. And I know when I first came into arthritis research as a layperson, there was a huge ramp up educational process. I had to try to figure out how to decode your language, and it wasn't something that was done easily. And I think our education community, our lay community that is trying to work with Indigenous peoples across the land, and you as expert researchers are walking forward to learn a new language, to deeply understand the cultural impact of racism, of Indian residential schools, intergenerational trauma. This is the setting of health for Indigenous peoples, and really encouraged when I hear you talk about the deep levels of consultation that you've undertaken. And I know how time consuming that is, but it's absolutely necessary.
Yeah, yeah, no,
And it's
absolutely.
a model, I think, that can be used across the country in terms of rheumatology research, because we have underserved Indigenous populations in every province, in every territory. The picture you painted of health in your own province for First Nations that you work with directly, as also and also Inuit, those are truisms across the country. The
Yeah.
outcomes are worse. The incidence and prevalence is much higher. It's horrible.
Yeah, and I have to, I have to take this opportunity to put, to promote a theme that you and I in our when we're in the Museum for Human Rights, that really struck me, which is the role of young people.
Yeah,
How disadvantaged they were through the residential school system and so on. But that quote that I saw at the Museum of Human Rights is. The young do not know enough to be prudent, so they attempt the impossible and they achieve it generation after generation. We have to capture the young people. We have to capture First Nations young people.
yeah,
And so we take great pride in having some of the best First Nations students engaged in our program and actively promoting their involvement in the research, their involvement with their communities, because I mean, this is true reconciliation, is
yeah.
to build the next generation.
Yeah, and these relationships have to be founded on equity, respect, humility, love, all of those things I know you've brought to your work for years. And I just, you've been a role model for a lot of people in your community, Dr. El-Gabalawy. Thank you for that. And I look forward to seeing the continuation of this research program that you've started with specifically First Nations people in Manitoba. And I hope to be involved with you in other relationships with Indigenous peoples that are going to ask questions, maybe even in a different way than we've asked in the past. The theme of the meeting is confluence and collaboration, and really focusing on shared decision making. You've been in your profession, in your medical profession, in your research career around for a long time. How have you seen, how has shared decision making benefited you, your work, your patients, your research partners, and how have you seen it change over the years?
Yeah, yeah, that's a great question.
Yeah,
And so the first, when I was first training, there was this, and certainly the generation before mine, there was this aura that physicians had, which is, you go in and you tell the patient what to do
yeah,
because, because of this kind of paternalistic, I know what's good for you, is that, and over the decades that you and I have been around and engaged in healthcare and healthcare delivery, I think there's been a clear shift to where people have become much more aware that they're dealing with gray zone, that physicians are dealing with gray zone, and that this decision making has to be based on trust, but it has to be based on a recognition that no solution is perfect.
yeah,
And you have to accept the fact that this is the best solution under this circumstances, and perhaps with wider consultation with a multi, not just the medical profession, but other sources of consultation. You would kind of weigh them together. So in this day and age, when you're sitting down and talking to a patient, you're saying, okay, here are your choices. And we're very fortunate that science has brought us along so we have choices,
yeah,
especially rheumatoid arthritis, when so when you're sitting down telling them the risks of this intervention versus the risks of that, I think we're all comfortable with that part of the shared decision making. I already alluded to the fact that if you're working in clinical research with First Nations communities in particular, there's not just individual risk to benefit discussions, but there's the whole
Community-wide, yeah.
community-wide, approval and consent of undertaking this. There's another level of decision making, which is basically your interaction with your host organization and your host healthcare, your hospital or your academic center, and there's shared decision making there as to what's possible, what are you allowed to do, what should you do, what's there funding to do, how is this impacting on the resources that are otherwise going to be spent on this, that, or that, the other. So at all levels, there is shared decision making on the individual level, on a community level, and certainly on an institutional level.
Yeah, as a patient myself, I often forget about that. I often and then who's going to pay for it?
Yeah.
How does it get paid for is also in the backdrop constantly. It's actually at every level of shared decision making is how you power what can be made available or not financially. You've been a great proponent, Dr. Gabalawy, about patient involvement in research. And I know that extends to your own rheumatology clinic. And I know when I was first diagnosed almost 35 years ago, I wasn't asked, well, what is it you want to try to accomplish with your treatment plan? But now that should be a leading question in the patient clinician conversation is, well, Cheryl, what are you hoping to do? Like, what do you want to get out of this? Because we do have options now. When I was diagnosed, we had 3 options. And none of them worked very well. Now we have, many options. And for some patients, they can work. And if they're initiated early enough, they can make it such that your life isn't even impacted by the disease. So I just, I love how you describe the different levels of shared decision making, that they happen in every aspect of medicine, basically.
Yeah, and I mean, it's not a situation where you and I will sit down and, oh, this is the best thing to do, and then you do it, because we know the constraints that we live in both financial constraints and operational constraints, logistical constraints. So I think you're right on by identifying decision making as at multiple levels that kind of we have to navigate through.
Is there a way to optimize shared decision making in your view? I mean, apart from what you've just mentioned, like understanding is key to optimizing.
Yeah. So
But is there a secret sauce in your mind?
No, there isn't a secret sauce, but there is on an individual level, first of all, there is ways of discussing risk with individuals so that they truly have informed decision making. And there was actually a very nice recent publication from Jeff Sparks in their rheumatology literature, just quoting the dialogue between the physician and the patient they're treating, the way you present risk. So let's say you're starting a biologic or a JAK inhibitor, something like that, and you say, well, there's a risk of cancer with this. How you describe that risk in a coherent way, while at the same time presenting the information factually, makes a very big difference. So that's a key, is the communication, on the one-to-one communication. In shared decision with a community, when you want the community to undertake a whole new approach to something, or in our case, the whole RA prevention agenda, you have to be honest. You have to have set realistic expectations. We're not gonna prevent rheumatoid arthritis in next year.
Yeah.
And you're working with us, so this is what we're trying to achieve short term, and so on. And then at the level of the institutional level, well, I don't have to tell you the kind of haggling that has to happen to make that happen. So anyway.
Yeah, I think shared decision making too. It's an N of 1 with your doctor, with your physician.
Yeah.
You can't just say this is this shared decision making formula that will lead to success. It varies by institution. If it's an institutional level discussion, it varies by research program in your team, and it certainly varies patient to physician. Because I'm an N of one. My journey with my disease is going to look very different, perhaps, than someone else, not because of the disease, but because of my life context.
Very much
And
so.
I think good clinicians understand that. You've certainly led the way in that understanding. So thank you on behalf of all of us out there, even when you're not all of our physicians, you've led the way in that thinking, I think, to the many that you've trained over the years.
Thank
I
you.
want to end our discussion, Dr. El-Gabalawy, with just ending on some of your thoughts around the patient's journey with disease. I'm not a big fan of the word patient because it actually, by definition, means passive recipient of care. And you know me well, I'm not passive about anything, so it doesn't describe me. I'm a person who happens to live with rheumatoid arthritis. That's how I think about myself in my own life. Um, and that gives me power, I feel. So when you look at it though through your lens as a physician, you're someone who has sworn an oath to provide, many different things in terms of the care that you deliver. But when you think about how to improve a patient's disease, their self-care practices, their own self-advocacy journey, um, what have you seen? What have you seen? Tell us your big pearl or your big kind of crescendo.
Yeah. Well, what I've seen is the emergence of Dr. Google. I think, yeah, this has been the single most important thing relevant to this point that you're making, is that patients, particularly patients with chronic diseases, are consulting multiple different sources of information that are available at their fingertips. And effective clinicians recognize that, and without being in any way punitive or revulsed by the fact that, oh, so and so is coming in with an opinion that is, recognizing that there are strengths and weaknesses to every bit of information that you get from anywhere. So the individual will go out and get information from their physicians, from their relatives, from online sources, for credible and not so credible. And ultimately, the challenge for an individual with a chronic disease is to understand the strengths and limitations of each of those sources.
Which is health literacy, which is
Yeah,
health literacy.
which is
Yeah.
health literacy.
Yeah.
Yeah, yeah. And then because exactly as you've identified that each individual's journey is unique, I've come to really recognize the importance of compromise. Is that the pursuit of perfection is destined to failure. In this world, you just, especially with chronic diseases that are so you have to ultimately compromise and say, okay, with a whole set of opinions about what I should do here, there, and how I should run my life and how I should treat myself. These are the compromises that I need to make to achieve the best outcome possible for myself right now.
Yeah.
And only an individual can do that. They have to be, we started out this discussion, we say you got to be true to yourself, and ultimately being true to yourself is recognizing that all of life is these compromises. And if your lot in life is you have a chronic disease for which there's a lot of things to do, for which there's a lot of people who feel differently about what the right thing to do is, you have to learn the health literacy part of it, learn how to navigate this and accept the compromises and do what's best in any one particular day, in any one particular circumstance.
Yeah.
That's my words of wisdom, and I know that I don't want to start quoting quotes, but I love the quote from the Canadian icon Leonard Cohen, ring the bells that still can ring, forget your perfect offering. There's a crack in everything. That's how the light gets in.
Wow. Well, from a antique microscope to the words of Leonard Cohen, I'd say we've gone from bench to bedside and back. Dr. El-Gabalawy, I can't thank you enough for spending the time with us in the hashtag See Arthritis event. I know this will be a much watched episode. We're going to offer some links at the end to some of those papers that you spoke about, hopefully lay versions of them. If they're an open access journal article, then folks will have it available to them. Otherwise, we'll try to do some knowledge translation on our own for them. So just know that we'll try to link to some of those things that you've talked about in some of your important research work. But I want to thank you again for taking the time to talk to us, not just about your life's work, really, but to talk to us in such a meaningful way about how you deal with your own patients. Because you're not only helping people like me understand, the clinical view, we think you're also helping your colleagues in rheumatology understand how you've been successful at rheumatology practice yourself. So we really appreciate that.
Thank you, and it's always a pleasure to talk to you, Cheryl. I mean, we've
Well,
done this for decades, so
we are part of a mutual fan club, to be sure. So
all the
thank
best.
you so much, Dr. El-Gabalawy. I hope we see each other soon.
You bet. Thank you.
Take care, everyone.